A healthcare shocker for millions of American women this week when a government panel recommended sweeping changes in how to detect breast cancer. The U.S. Preventative Services Task Force says most women in their 40s do not need mammograms. The advice flies in the face of the American Cancer Society, which for decades has urged women to start getting mammograms every year, starting at age 40. Right now, we're joined by breast cancer expert Dr. Mahmoud El-Tamar from New York Presbyterian, Columbia University. Good morning.
Good morning to you.
What does this mean for women 40 to 49?
Well, that is a very serious recommendation. Previously, the recommendation was a mammography every year or every other year, and now the recommendation is to do nothing. And the basis of that, the basis of that recommendation is you have to weigh the risks and the benefit. And the benefit is there is the decrease in mortality for women who get screening, and this is approved and accepted even by the task force that made those recommendations. The approximate risk reduction in mortality for women who get screened within that age group varies between probably 10 to 23%. On the average, we usually accept a number of 15%. So there's no doubt women between the age of 40 or 49, if they get screened, there's a decrease in their mortality from breast cancer by approximately 15%. The downside of screening women is what are the possible side effects. And the task force lists 3 side effects. One is overdiagnosis. And what do we mean by overdiagnosis? It means you diagnose cancers that will not impact the lifespan of a woman.
And so these women are getting then biopsies that they don't necessarily need?
Well, let's get to that point in a little bit. But let's address the issue of overdiagnosis, which means you diagnose a woman with a cancer, but that cancer may not eventually be life-threatening. Okay. Now, how frequently do we diagnose women who are not or diagnose women with cancer that is not life-threatening? In that age group, most cancers are life-threatening. It would be hard to believe that a woman between the age of 40 and 50 who's going to have a lifespan of approximately 40 or 50 more years to live, if she has small cancer cells, those cancer cells are going to stay put for the rest of her life. Now, if you diagnosed a woman at the age of 75 or 80 with some cancer, she may die with that cancer, but probably she will not die from that cancer. In the age of 40 to 50, a diagnosis of breast cancer is serious. So the issue of overdiagnosis in that group is not that significant.
So let's talk about the people on the task force, because they're making decisions for potentially for many millions of women. Who are these people who are deciding this?
Well, these are very smart people. They are dealing with public health policies. There are deans of schools. There are directors of programs. But I don't know, and I'm not aware of how many members of that task force are basically people who deal with day-to-day care of patients with breast cancer. I'm not sure how many are radiologists who do mammography. I'm not sure how many are breast cancer surgeons, how many are medical oncologists. Right. If you look at the list, most of these are very smart people who really deal with public health policies.
And so how much of this factors into the money issue? Because I know that there's been some talk that not screening from 40 to 49 will save money, but what about on the back end?
Well, I mean, this is where we're talking about, is it really going to save money on the long run? If we take that screening because you're going to diagnose one patient out of every 50 women who are screened between that age group, the risk of getting breast cancer is 1 in 50 in that age group between 40 and 49. So is it worth to spend all that money to diagnose a case and save mortality of 10 to 15%? Well, if you make those calculations, one would say we'll probably save money. However, you have to think that we will be diagnosing those patients at a later stage. So we're going to be treating those patients with more chemotherapy, with more radiation therapy, with more surgery. And that has a cost by itself. And I'm not sure there's any study that looked into that over-treatment that we'll have to do if we delay the diagnosis of these patients. And eventually that will result in saving money if we take that screening away. So I'm not sure of that economical formula that really makes sense.
All right, Dr. El-Tamar, we really appreciate your analysis. Thank you.
Thank you.